What is the most common cause of anemia in hospitalized patients? The anemia of chronic inflammation is commonly associated with systemic diseases, including chronic inflammatory conditions, rheumatoid arthritis, chronic infections such as tuberculosis and HIV infections, viral infections, malignancies. So, this is very common in the hospital, and it is the second most common type of anemia in the world, second only to iron deficiency anemia. The initial anemia workup involves a CBC with differential and retic count. So when we run the CBC, there are flags, and we must do a peripheral blood smear exam. And what do you expect to see? Microcytes and hypochromasia. This is consistent with a microcytic hypochromic anemia. We'll use the CBC definition of anemia where there's a decrease in the red blood cell count and hemoglobin and hematocrit are below reference ranges. And we'll use the ASCP Border Certification Reference Ranges, 7th edition. We'll use the morphological classification of anemia based on mean cell volume, where the microcytic anemias are classified as those with MCV below 76 femtoliters. And microcytic anemias, MCV less than 76, the most common one is iron deficiency anemia. But there's also anemia of chronic inflammation, thalassemia, hemoglobin E disease. Sideroblastic anemias include the hereditary and acquired, like lead poisoning, and drugs and toxins can also cause a sideroblastic anemia. How does chronic inflammation affect so many people with anemia? The key to understanding the pathophysiology of anemia of chronic inflammation is knowing that it is caused by impaired ferrokinetics and thus iron-restricted erythropoiesis. Activated macrophages signal an inflammatory response with interleukin 6, one of the acute phase reactants. Hepcidin is a hormone produced by the liver to regulate iron release of intestinal macrophages and hepatocytes. Hepcidin degrades ferroportin, which exports iron from intestinal cells to the blood. Sequestration of iron by macrophages is thought to be an immune defense mechanism against invading bacteria, which needs iron for their cytochrome reactions. Lactoferrin is a very interesting acute phase reactant, which you see it in neutrophils, the secondary granules, the specific granules, where you have sequestration of iron, and it will keep it and trap it away from the viruses, bacteria, fungi, and parasites. It is also naturally occurring in milk and is found in saliva and secretion, so it is an interesting part of our innate immune system. So we see that iron transport, storage, and ferrokinetics are both fascinating yet very complicated. But let's have a few take-home messages from the schematic. We already know that hepcidin, the hormone secreted by the liver, is an acute phase reactant, and it has a regulatory function for intestinal macrophages on iron absorption, and also ferroportin. It regulates it, degrades it for transport to erythroid precursors for iron binding. And we also know that we have sequestration of iron by liver macrophages, intestinal macrophages, as well as in the bone macrophages. So we have trapped iron, but there's not available iron for free iron for the erythropoiesis for the erythroid precursors. And this is a problem with the anemia. A couple other key points. Note that serum iron is decreased and TIBC is decreased. TIBC is an indirect measure of transferrin, and decreased TIBC reflects an abundant iron stores in hepatocytes. Two other lesser factors of the pathophysiology of anemia of chronic inflammation include production of inflammatory cytokines such as tumor necrosis factor and interleukin 1 from activated macrophages, which impairs erythropoietin produced from fibroblasts of the kidney, resulting in diminished erythropoiesis of the bone marrow. Also, shortened red blood cell lifespan is thought to be caused by extracellular hemophagocytosis by hemophagocytic macrophages in the liver and spleen. Know the key differentiating lab tests between iron deficiency anemia versus anemia of chronic inflammation. In both cases, you have low iron levels and low transferrin saturation levels. But look at the ferritin levels. They're opposite, and TIBC opposite. In ferritin, you'll see it low in iron deficiency anemia, but high in anemia of chronic inflammation. And the TIBC, it's high in iron deficiency anemia, but low in the anemia of chronic inflammation. And if there was a bone marrow, you will not see iron granules in iron deficiency anemia, but you will see iron granules in anemia of chronic inflammation. In a bone marrow stain, Prussian blue is used to see iron granules, but for anemia of chronic inflammation, you don't need a bone marrow. You need iron levels, ferritin levels, TIBC, transferrin saturation percent, and this is very helpful with the diagnosis, along with a soluble transfer receptor assay. Just an FYI, soluble transferrin receptor assay is useful for differentiating iron deficiency anemia from anemia of chronic inflammation, but I didn't see this in our study guide for ASCP. Let's look at a few questions that are similar to the board of certification study